Hello guys, today we will talk about gallstones, diagnosis, taxes and treatment. And of course, first of all, I want to show you this picture. It is really most expensive with knowledge. Yeah, you see the gallbladder, liver, you see the common bile duct, you see the duodenum, and you see the stone. Yes, what are coming from gallbladder, or sometimes they can come in not from gallbladder, they can come in from bile duct, but it's rare situation. There you see the symptoms: colicky, upper right quadrant pain, jaundice, diagnosis, blood test. Yeah, for us is interesting. About aminotransferase and aspartate aminotransferase. Transabdominal ultrasound, it is a gold standard of the diagnostic of gallstones. Treatment, ERCP, it's when we talk about the um, gallstones, stones inside the bile ducts, and cholecystectomy, it's when we talk about the uh, stones inside the gallbladder. Risk factors: obesity, high calorie diet, sudden weight loss, medications, liver disease. Types of gallstones: cholesterol, most common time, more than 80% of cholesterol. Pigment, mainly bilirubin salts, less than 30% of cholesterol, and mixed. 30–80% cholesterol contain calcium salts and biliary acids. I think that it is more expensive picture for you, and if you will understand this, you will understand all topic, and if you remember this, you will have three, I think, so, in the examination. Incidents: in most Western countries and certainly in Australia, gallstones are the most frequent gastrointestinal surgical cause for admission to hospital. In Australia, for example, the gallbladder is the most frequently removed organ, and approximately 50,000 cholecystectomies are done each year. The incidence of gallstones varies widely depending on the demographic group. In Australia, the incidence of gallstones is estimated to be 10–15%, and most of these patients are asymptomatic. In comparison, the incidence of gallstones amongst Black sub-Saharan Africans is less than 5%. In Asian populations, the incidence may be lower, but as more Asians are exposed to high-fat Western diets, this incidence is on the increase. There you see the picture, is the same picture: gallbladder, cystic duct, hepatic duct, gallstones, common bile duct, pancreatic duct. And I pleased you to remember this picture because it is important, and this picture we pleased you show us in the examination. The incidence of gallstones among the indigenous peoples of Chile is 49% in women and 12% in men, whereas the indigenous peoples in North America may have the highest reported rates, with up to 29% of men and 64% of women developing gallstones. Gallstones are the chief risk factor for the development of gallbladder cancer. This is important. Gallbladder cancer is rare in Western countries, but more common in Chile. Importantly, the incidence of gallstones increases with age, and this is a significant issue, especially in Western countries with aging populations. In particular, gallstones are much more frequent over the age of 40. A British autopsy study showed that the incidence of gallstones in women aged 50–59 years was 24%, and this increased to 30% in the ninth decade. The same study showed that amongst men the incidence increased from 18% in those aged 50–59 years to 29% in the ninth decade. Types: gallstones are essentially crystals that develop in the gallbladder. However, in some circumstances, They may develop outside the gallbladder, primarily in the bile duct. In 80% of cases in Western countries, the gallstones will be cholesterol or mixed stones which contain calcium. In the picture, you see the types of the gallstones. Pigmented stones are black or brown in color. Black stones are generally associated with hemolytic conditions and are small, and composed predominantly of calcium, bilirubinate, and mucin glycoproteins. Brown stones are more commonly seen in Asian populations and are associated with parasitic or bacterial infections. Unlike black stones, they more commonly form in the biliary passages. And now we will talk about bile production and the enterohepatic circulation. Bile acids are formed by two pathways. First, the classic pathway occurs only in the liver, as it requires the enzyme cholesterol 7-alpha hydroxylase, which is found in the hepatocytes, to hydroxylate acetyl nucleus. The alternate pathway occurs in the extrahepatic tissue such as the kidney, macrophages, and vascular endothelium, where the enzyme oxysterol 7-alpha-hydroxylase oxidates cholesterol to oxysterols, which are then transported to the liver, where the primary bile acid, cholic and deoxycholic acid are formed. In healthy individuals without liver disease, the alternate pathway only contributes 10% of viral bile acid synthesis. Um, Go forward. After the bile acids are synthesized in the liver, they are conjugated with either glycine or taurine and are then secreted into the bile ducts and stored in the gallbladder, where concentration of the bile occurs. When a meal is eaten, the gallbladder is stimulated by cholecystokinin, and the gallbladder empties 70–80% of its contents into the bile duct and subsequently into the duodenum and small bowel. Once in the intestine, the bile forms micelles and is responsible for digesting fats, fat-soluble vitamins, and some drugs. It is thought that the primary cause of cholesterol gallstones is the presence of cholesterol supersaturated bile, cholesterol supersaturated bile, cholesterol supersaturated bile, which is litogenic. This litogenicity may be modified by factors within the bile such as excess cholesterol, change in the biliary and bowel microbiome, low bile salt levels, abnormal lipid transport, mucus secretion, and impaired gallbladder emptying. The production of bile acid is the main pathway of the exportation of cholesterol, accounting for about 50% of daily exertion. In a healthy adult, the liver produces 600–7,500 milliliters of bile per day. And I will repeat, bile made in liver, stored in gallbladder, helps with digestion, absorption of fats, emulsification and solubilization, extraction, uh, composition, bile salts, phospholipids, cholesterol, bile pigments. Bile production and the enterohepatic circulation. Once primary bile acids are secreted into the bowel, some are deconjugated to secondary bile acids by intestinal bacteria. In the ileum, some of the secondary bile acids are reabsorbed passively, whereas the conjugated bile acids are reabsorbed by an active transport system. In most individuals, 95% of bile acids are reabsorbed in the ileum and transported back to the liver, and only 5% are excreted via the large bowel. If there is increased secretion via the large bowel due to a variety of causes, such as ileal resection, previous cholecystectomy, inflammatory bowel disease, or radiation therapy. This may be associated with the development of chronic diarrhea. Risk factors. In the majority of patients who develop gallstones, the causes are multifactorial, of course. However, there are many factors that predispose to gallstones that are modifiable. The causes of gallstones include the following: age. As previously noted, the incidence of gallstones increases with age. Gender. Females are at least twice as likely to develop gallstones as men, at least up to menopause. This is probably related to both endogenous estrogen and the oral contraceptive. Pregnancy. This is an independent risk factor for the development of gallstones. It is common for women to develop symptoms during pregnancy, and this is because of increased estrogen secretion, which results in increased biliary sludge formation. This may resolve after childbirth, but may result in definitive persistent gallstones in about 5% of women. Obesity and dietary factors. Obese individuals have a higher risk of gallstones compared with lean individuals. It has been estimated that the relative risk of gallstones is increased by factors of at least 2 in both men and women who are obese. Morbidly obese women, BMI more than 32 grams, have an even higher risk of gallstone formation with an age-adjusted relative risk of a diet which leads to increased obesity increases the risk of gallstone formation. It does appear that any diet which is high in fats and cholesterol increases the risk of gallstones formation. Conversely, the risk of gallstones may be reduced by a low-fat diet, legumes, and a moderate intake of alcohol. Certainly, it does appear that some ethnic groups who have a low risk of gallstones formation, such as Native Americans, may form gallstones at an increased rate with exposure to a Western diet, which is usually low in fiber and high in refined carbohydrates and fat. Rapid weight loss is also associated with an increased risk of gallstone formation. Genetic predisposition. Of course, gallstones often run in families, with an increased risk of gallstones formation related to family history. As noted earlier, the incidence of gallstones formations varies for different ethnic groups. Total parenteral nutrition is a known risk factor for cholelithiasis. It was recognized some time ago that seriously ill patients in intensive care on TPN were at increased risk of acalculous cholecystitis. However, more recently it has been recognized that many of these patients do in fact have microlithiasis. It has been shown that for seriously ill patients in intensive care that biliary sludge may appear after a few days of fasting. Biliary sludge will appear ultrasonographically after 4 weeks of TPN in up to 50% of patients, and this may increase the longer the TPN is continued. After cessation of TPN, many instances of microlitis will resolve rather than progress to gallstone formation. The mechanism of gallstone formation may be related to ileal atrophy due to TPN. Hemolytic disease, particularly in sickle cell disease, hereditary spherocytosis, and hereditary eleptocytosis, where there risk chronic hemolysis and leads to increased bilirubin secretion with the formation of black pigment gallstones. Other chronic disease. Ileal Crohn's disease is associated with an increased incidence of gallstones. Likewise, cystic fibrosis is associated with an increased prevalence of gallstones. Cirrhosis is associated with an increased prevalence of gallstones formation. Spinal cord injury is associated with a significant increase in the risk of formation of gallstones, possibly due to gallbladder stasis. Drugs. Those which may increase the risk of gallstones formations include thiazide, diuretics, ceftriaxone, and octreotide. Conversely, statins may decrease the risk of gallstones formations. Biliary colic and acute cholecystitis. It is estimated that 10–15% of the population in Australia, USA will have gallstones. However, most people with gallstones are asymptomatic. It is estimated that each year 2–4% of people with gallstones will develop symptoms, and generally once symptoms develop they will continue. Also, this is unpredictable and may be modified by change in diet and other factors. Most patients who develop symptoms related to gallstones will develop biliary colic. This usually manifests as epigastric and right upper quadrant pain that may radiate to the back and often follows a fatty meal. This is often associated with nausea or vomiting, and there may be a history of fatty food intolerance. The pain may vary from relatively mild to excruciating. The pain is caused by a stone bulging in the outlet of the gallbladder, and the pain may resolve suddenly with dislodgement of the stone. If the stone does not dislodge, the blockage of the gallbladder outlet or cystic duct causes increased pressure within the gallbladder. The bile is then forced into the wall of the gallbladder, resulting in edema and inflammation. As the pressure increases, this causes renal ischemia, which can lead ultimately to necrosis of the wall of the gallbladder if the process is not arrested. Pathophysiologically, this can result in an empyema of the gallbladder, where the gallbladder is full of pus or indeed perforated. This infection may result in translocation of bacteria, resulting in bacteremia or indeed septicemia. The most common organisms involved in this process are gram-negative organisms such as Escherichia coli, Klebsiella, or Pseudomonas. Other organisms that may be present include Clostridium, Staphylococcus, or Salmonella. Acute cholecystitis is associated with persistent right upper quadrant pain and tenderness. Nausea or vomiting is frequently present as the patients are often febrile. Murphy sign, when an examiner notes that the patient stops breathing due to pain over the inflamed gallbladder, is helpful in diagnosing acute cholecystitis, but its absence does not exclude it. Table 1. I will show it after. The severity of acute cholecystitis is highly variable and influences the choice of treatment. Influences. The Tokyo guidelines are an attempt to grade the severity of acute cholecystitis and are widely used by clinicians. Table 2. I show it too. Table 1. Tokyo diagnostic criteria for acute cholecystitis. How you see local signs of inflammation, Murphy signs, and drug mass pain tenderness. Systematic signs of inflammation, fever, elevated CRP, elevated WBC. See imaging findings. This characteristic of acute cholecystitis. And different diagnoses, one item in A and one item in B are positive. And the second one, C, confirms the diagnosis when acute cholecystitis is suspected clinically. Tokyo guidelines for severity of acute cholecystitis. Table 2. Grade 1, grade 2, and grade 3. There can you find this classification. Gallstone pancreatitis. Gallstones are the most common cause of complaint in Western countries and account for 60–70% of cases. In the majority, the pancreatitis is mild and self-limiting. It may be severe in 20%. In such cases, mortality may approach 20–30%. Gallstones pancreatitis is increasing in incidence in Western countries and has an estimated incidence of about 30 per 100. 100,000 population per year. It is most common in women in their 60s. Also, the association between gallstones and pancreatitis was first described in the 19th century. The mechanism was not well understood. It is now believed that a stone passing through the sphincter of Oddi causes irritation, edema, and temporary obstruction to the pancreatic duct, resulting in outflow obstruction to the pancreatic duct and raised intra-abdominal pressure. These cases a cascade of biochemical reactions which result in release of pancreatic enzymes and edema of the pancreas resulting in inflammation. If the process continues unabated, this results in further inflammation, release of inflammatory cytokines, and the systematic inflammatory response syndrome. The severity of the pancreatitis is unpredictable, but it may be that increased time of obstruction to the pancreatic duct is associated with more severe cases. Risk factors for gallstone pancreatitis include multiple small stones and a delayed cystic duct. Gallstones are found in the face of up to 90% of patients with gallstone pancreatitis. A minority of patients with cholelithiasis develop gallstone pancreatitis. Of those patients with symptomatic gallstones, the annual risk of developing gallstones pancreatitis is about 1%. Medical tests and changes. Gallstones present in the biliary tracts are common. The earlier that are the highest risk and chances of abnormal liver function test may be their presentation. Up to 20% of patients with gallstones may present in this way. It may or may not be associated with pancreatitis or cholangitis. Cholangitis was first described by Charcot in 1887 and was termed hepatic fever. Charcot's threats consist of fever accompanied by rigorous jaundice and right upper quadrant abdominal pain. It can be defined as acute inflammation and infection in the biliary tract. It requires elevated bile duct pressure, usually due to some form of obstruction and the presence of increased bacteria in the bile duct. The cause of cholangitis as summarized in Table 3. Then you see the causes of acute cholangitis. Cholangitis is a medical emergency that requires prompt treatment. The mortality may approach 10% overall and is higher in elderly patients with significant comorbidities. Charcot's triad as diagnostic criteria for cholangitis is not adequate. Although the specificity is probably greater than 90%, the sensitivity is low at about 25%. As such, the Tokyo guidelines are a better method of diagnosis in acute cholangitis, and there is a set out in Table 4. Likewise, there is a severity assessment, Table 5. Near Table 4, diagnostic criteria for acute cholangitis, you can see it on the left chart, and Table 5 is simple as severity assessment criteria for acute cholangitis. 1, 2, 3. Visualization of gallstones into the bone. Good picture for understanding. This is uncommon but may be seen rarely but more commonly in elderly patients. A large gallstone may obstruct the bowel if this occurs. The obstruction will more commonly occur at the ileocecal valve, Barnett syndrome, but may occasionally obstruct the duodenum, Bullard syndrome. Gallbladder cancer is rare in Western countries but highly lethal. In Australia, the incidence is less than 2 per 100,000 population per year. Gallstones are significant risk factor for gallbladder cancer, with more than 75% of patients having gallstones. The relative risk of gallstones causing gallbladder cancer is 4.9. Diagnosis: baseline hematological and biochemical investigations. Elective investigation of a patient with gallstones should include a routine full blood count, recurrence, and liver function test. Up to 10% of patients who present electively may have cholelithiasis, the presence of which may be suggested by abnormal liver function test. If there is a history of jaundice, it is important to determine bilirubin and alkaline phosphates concentration and eye international emergency return. In the patient who presents with abdominal pain, measurement of stereoactive protein to estimate the degree of inflammation is helpful, and amylase and lipase levels should be done to exclude pancreatitis. Staying on the note tray, this has limited usefulness. Only 15% of gallstones will have enough calcium to be seen in a plain abdominal X-ray. Ultrasound: this is the investigation of choice for gallstones and avoids ionizing radiation, which is particularly important in young people. Good quality ultrasonography has a sensitivity and specificity in excess of 95% in uncomplicated cases. Obviously, previous surgery and bowel gaze may impede the accuracy of the test in diagnosing gallstones. The stones are shown by a bright echogenic appearance with posterior shadowing, and how you see it on the picture. Stone and this is shadow. Ultrasound have variable accuracy in diagnosing choledochondritis with a sensitivity of 50–80% but specificity over 9. Ultrasound is also useful in diagnosing cholecystitis by demonstrating tenderness over the gallbladder associated with thickening of the gallbladder wall more than 4 mm, and sometimes fluid collections. It is accurate in demonstration masses of polyps within the gallbladder and will show if there is abnormal biliary dilatation. An abdominal CT scan is not recommended in the routine diagnosis of gallstones. It may have a place in imaging for severe complicated cholecystitis, but has low sensitivity and specificity for diagnosing gallstones in the gallbladder than ultrasound. It is also carries the risk of exposure to ionizing radiation and higher costs than ultrasound. Abdominal CT scanning is the diagnosis of choledochondritis, has a sensitivity of 68% with a specificity in excess of 95%. CT cholangiography is infrequently performed because of the risk of allergic reactions, but does increase the sensitivity for the diagnosis of choledochondritis to 85–95% and the specificity to 88–98%. Endoscopic ultrasound. In Australia, this technique is becoming more widely available and also not a first-line investigation for the diagnosis of gallbladder gallstones is very accurate. In the diagnosis of choledochondritis, it is even more accurate, with a sensitivity reported as 89–94 and a specificity of about 95%. The disadvantage is that it requires specialized equipment and training and cannot be done on an outpatient basis. It is most useful in patients where the diagnosis is uncertain. MRI cholangiopancreatography. MRI cholangiopancreatography is the diagnostic modality of choice for choledochondritis. It does not involve ionizing radiation. The disadvantages of the modality relate to its cost, limited availability, patient claustrophobia, and previous procedures such as placemakers pacemakers, which may contraindicate it. However, the technique is highly accurate in diagnosing polydactylitis with a sensitivity of 92% and a specificity of 99%. Endoscopic retrograde cholangiopancreatography, or ERCP, is uncommonly used as a diagnostic test and is a therapeutic tool to clear the bile duct of stone. There are rare but serious complications such as bleeding, bowel perforation, and pancreatitis. Laparoscopic ultrasound. This is sometimes used at the time of laparoscopic cholecystectomy to diagnose common bile duct stones. Technetium labeled hepatoimmunostatic acid. This test has little use in the diagnosis of gallstones but may be useful in diagnosing acute cholecystitis or chronic acidosis cholecystitis. Treatment we can relate for asymptomatic gallstones and symptomatic gallstones. When we talk about asymptomatic gallstones, there is little evidence to justify treating asymptomatic gallstones. Likewise, there is little evidence that lifestyle modification will lower the risk of developing symptoms related to gallstones if they are found incidentally. There are situations where a discussion with a patient with asymptomatic gallstones is important. For example, in a patient who requires a heart transplant where the risk of biliary sepsis is significant, where a patient is going to spend a significant period in a remote area such as uh, Antarctica, or with a patient whose ethnic group has a high risk of gallbladder cancer. And there may also be occasional circumstances where a patient has to undergo surgery for another reason, and it may be reasonable to consider removal of the gallbladder at the same time. Symptomatic gallstones, non-operative and cholecystectomy. If we talk about non-operative, some patients are able to control their symptoms for a significant period of time with a low-fat diet. Unfortunately, most patients find that they are unable to stay on the diet and recurrence of symptoms is common. There are a variety of herbal and naturopathic treatments and diets which are reputed to dissolve gallstones or alleviate symptoms, but there is little evidence to support this approach. Dissolution therapy with ursodeoxycholic has been shown to have a low rate of cure, with only 27% of patients exhibiting dissolution of stones after treatment and a high rate of recurrence. Lithotripsy, B. carefully placed extracorporeal shock wave therapy, or lithotripsy, is highly successful for renal tract stones and has also been tried for gallstones. And of the major issues is that breaking up gallstones results in multiple small stones that may be more likely to pass into the biliary tract and cause pancreatitis and other complications. Lithotripsy may cause dissolution of stones in up to 55% of patients, but more than 40% of patients will develop regular gallstones within 4 years. This treatment is also limited by expense and availability. But I just need to tell you about this one. Cholecystectomy. Removal of the whole bladder in the patients who are fit for surgery is the treatment of choice in symptomatic gallstones. This is usually performed by a laparoscopic technique due to shorter lengths of hospital stay, less pain, shorter return to work, and better cosmetics. It usually involves 4 or 5 small incisions of 1 cm in length. The majority of for elective procedures can be done with an overnight stay. Also, there is no good evidence that a majority of elective procedures can be done as day-only admissions. In many centers in Australia, the procedure is accompanied by an operative cholangiogram to check the anatomy and exclude cholecystectomy. In elective cases, the 30-day mortality is under 0.5%. and the majority of patients will have recovered fully within 2 weeks. However, the risk associated with the procedure, including infections, need to convert to an open procedure, bile leaks, pneumonia, and deep venous thrombosis. The most feared risk is a bile duct injury. This will usually be a result of misidentification of the anatomy. When laparoscopic cholecystectomy was introduced, there was an increase in the incidence of this complication. This risk now appears to have stabilized, and the mere transaction of the bile duct probably occurs at a rate of about 1 in 800 cases in Australia. Emergency procedures carry a high risk of complication. An emergency laparoscopic cholecystectomy can be an extremely difficult procedure due to the difficulty in identifying the anatomy. Occasionally, it may be impossible to perform a complete cholecystectomy, and the surgeon may consider a cholecystectomy where the gallbladder is drained or a subtotal cholecystectomy. In the acute situation, where the patient is extremely ill and not fit for operation, a percutaneous cholecystectomy performed radiologically may be an option to allow the condition to settle, followed by a laparoscopic cholecystectomy when the patient has recovered. Most patients will not notice significant digestive problems after removal of the gallbladder. A small proportion will develop fatty food intolerance that may be quite individualistic, and there is also an incidence of bile salt-induced diarrhea. In the patient who does not require hospital admission for biliary colic, the procedure can be planned electively. However, this does depend on the resources available. If the procedure is likely to be delayed for some months, then there is a high likelihood of representation to the hospital and a high risk of prolonged hospital stay and other complications. In the patient who presents with acute cholecystitis and requires hospital admission for intravenous antibiotics, the timing of surgery is controversial. The consensus is that early surgery in this group may be associated with a high risk of conversion to an open procedure and an increased risk of BDI and other complications. However, there is no good evidence from meta-analysis that early operation is associated with a more rapid recovery with no increase in complications than delayed operation after the cholecystitis has settled. Likewise, in the patient who presents with acute pancreatitis related to gallstones, the timing of surgery is controversial. There is an argument that some delay in removing the gallbladder is appropriate because there is a risk that the pancreatitis may worsen, particularly in the first 48 hours. This is a clinical decision as to when operation should be performed, and there is move to perform an cholecystectomy on the index admission depending on resources available. In any case, removal of the gallbladder within 4 weeks is regarded as best practice to avoid the risk of repeated episodes in the patients with mild complicated pancreatitis. Thanks for attention guys, and have a nice